Good afternoon, everyone, and welcome to the Recovery Science Echo, brought to you by BWell Texas and the Center for Substance Use Training and Telementoring CSTAT. My name is Shreya Prasad, and I will be facilitating today's session. A few quick housekeeping notes before we begin. To help us with attendance, please enter your name, email, and affiliation in the chat. To access the chat feature, click on the speech bubble icon at the navigation bar on the bottom of your window. To all the BWell Texas providers, please make sure that you identify yourselves during the session by entering your information into the chat, or if you're joining by phone, please email your phone number and name to bwelltx@ithaca.edu. We encourage everyone to join by video for the discussion portion in the latter half of the session. That said, regardless of how you're joining up here, we are just happy you're here to learn alongside us. We are recording these sessions for later distribution through the BWell Texas YouTube channel. Any information that you put in the chat will not be shared in the recording. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you are joining by phone, just press *6 to unmute. You can also use the reactions menu in the bottom right of your Zoom screen to raise your hand and indicate you have a comment to share. You can also use the chat to share your questions and perspectives. There are a lot of us in the space, so please keep your comments brief to allow others to speak up. And finally, please note that no protected health information is allowed either in the chat or in the discussion, and that includes names, emails, addresses, or anything that can easily identify an individual. Towards the end of the session, our wonderful IT support, Karen, will be sending out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities and allows you to access free continuing education credits. This is a unique series, and we are offering CMEs today. We would also like to hear from you, the participants, what type of CEs you are interested in receiving during these sessions. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on options and considerations for measuring progress in recovery, and this will be presented by Dr. Bettina Hoeppner. Following that, we will discuss a case presented by Dr. Angela Hageman and Dr. Craig Henderson. We will start with introductions, followed by didactics, announcements, case presentation, and open discussion. Thank you all again for joining today. These sessions are what we make of them. We encourage you all to share your perspectives and insights in today's conversation. And with that, we will do some introductions. Sierra.
Hi, I'm Sierra Castedo de Martel. I'm a postdoctoral fellow at Chestnut Health Systems Lighthouse Institute, and I am one of the hub members.
Thank you so much for joining us today. Emily.
Hi, I'm Emily Hennessy. I'm Associate Director of Biostatistics at the Recovery Research Institute at Mass General Hospital, and also one of the hub members.
Thank you so much for joining us. Cheryl?
Hi, Cheryl Pacapelli, person in long-term recovery, and I'm the project director at Harbor Care, overseeing the statewide recovery community center network, and part of the hub people. I don't know what we call ourselves. We're the hub. So glad to be here. Thanks.
Thank you so much. Bettina.
Hi, my name is Bettina Hoeppner. I am an associate professor at Harvard Medical School, Mass General Hospital. I'm the director of the Healthful Flourishing program in the psychiatry department there. Glad to be here with you all today.
Thank you so much. Angela?
Apologies, it takes me a minute to find mute sometimes. Angela Hegeman, I'm co-director of the East Tennessee State University Addiction Science Center. Glad to be here.
Thank you so much. Craig.
Hi, good afternoon, everyone. My name is Craig Henderson. I'm a professor in psychology at Sam Houston State University. I direct our PhD program in clinical psychology, and I'm part of the FIRST Research Network, the R24 in course.
Thank you so much for joining us today. Daniela?
Hi all, I'm Daniela. I'm the project manager for the Peer Recovery Innovation Network grant, or PRIN for short, here at UT Health San Antonio. So good to see you all.
Thank you so much. And with that, we will move on to our didactics for today. Dr. Hoeppner, you can take it away whenever you're ready.
I should unmute myself. That would be better. I'm ready if you guys can start screen sharing, and please do call me just Bettina. That'd be fine. And for all of you guys, I'm happy to take questions as I go. I'd much rather, rush through some slides at the end if it means we can have a fruitful discussion along the way. So, but at any point, please interrupt me. All right, today we get to talk about one of my favorite subjects and topics, which I know also at the conference next week from the course network of a Consortium on Addiction Recovery Science. There's a number of sessions actually on measuring recovery. So I'm probably going to see a lot of you there. And I will share some of the thoughts from our team. If you can go to the next slide. Oh, right, disclosures. These are not actually my own slides. So do you want me to read those, Shreya, or can we just show them? All right, show them and go to the next.
It's fine.
So no disclosures, and move on to the next one. These are the learning objectives, which I will also have on my outline of slides in a moment. So the goal is for you all to get some feedback on some measures of recovery, to give you concrete examples of things we have chosen, and to identify, to direct, show you some repositories. All right, next slide, please. So here is the order in which I will actually be doing things today. So the first piece is I'm just very briefly going to share some slides on why we need to talk about measuring recovery. Then I'm going to show you some options for a scale team might consider as you're measuring recovery and the results of peer recovery support services. Then I will share feedback from RCC directors that we have been able to gather. And lastly, I'm going to share a concrete example just as a way to show an example, because I find examples motivating. And of course, for your own projects, you'll probably choose something else, but it's maybe helpful to see examples. And I already mentioned, please do interrupt me as I go along. All right, next slide, please. So I don't think I can actually see it if people raise their hands or anything. So please just unmute yourself and ask your question as you need. All right, so why discuss outcome measures? This wonderful link here that you can follow leads us to the NIDA website, and which talks about recovery support services. And one of the things that they are highlighting here, of course, is that recovery support services provide a variety of non-clinical services over the long term, but their effectiveness has not been adequately studied. And that's absolutely true, and that's why we are all here, because we want to study their effectiveness, and we want to study how they work and in what context they work and all the different issues that are involved. But the effectiveness, if we want to talk about effectiveness, means that we need to have an outcome measure that we can all agree on is meaningful. So the question becomes, how do you measure this effectiveness? And the challenge here is that recovery is multifaceted. And in my case, our R24 network focuses on recovery community centers. In our case, RCCs are complex entities and they operate in unique settings, so that further complicates it. And I'm sure for many of you here, this is also true. You may or may not be at an RCC, and if you are in an RCC, please let me know. But I think that there are many different settings in which peer recovery support services work takes place. Angela has some great information on that, which I'm sure she'll share. All right, moving on to the next slide. So in the past, hopefully, maybe, in terms of clinical treatments, when we talked about what is the success for SUD treatment, it was often defined as abstinence, which is used in many clinical trials that seek to evaluate the effectiveness of treatments for opioid use disorder, and particularly also medications for opioid use disorder. And then the other one, if you're not talking about abstinence, we talk about treatment retention. And that also gets used quite a lot in the literature. And these, of course, aren't great measures of recovery. We go to the next slide. So increasingly, papers are coming out that are highlighting things that are missing from a focus on just abstinence and retention and formal treatment. So for example, there was a study published in 2022 by Hooker and al. that did interviews with both clinicians and patients about outcomes for treatment. And they both agreed what is important to also measure beyond these two things is staying sober, taking steps to improve physical and mental health, improved psychological well-being, improved relationships, improved role functioning. And then patients also added that one of their goals for for opioid use disorder treatment would be tapering off of the medications and having their shift in identity. And they are by no means the only people who have found this. Another study by Reed in 2023 found very similar things, where the outcomes that people really want to talk about is emotional well-being, as well as attendance to basic functioning, and of course, decreased drug use, not abstinence. So moving forward to the next slide. This, of course, is not news, I think, in this group right here. SAMHSA's definition is certainly multidimensional, as is the definition by NIDA. So the question for us as researchers in this field becomes, what do we do? What kind of measure captures what SAMHSA has in mind, what NIDA has in mind, what patients have told us, what providers have told us, what all the number of different studies that have been done in the recovery field about defining recovery, which all show that recovery is multidimensional. Next slide, please. All right. Sorry. So there are a couple of places, if you're looking for suggestions for how to measure outcomes, I would certainly start with the Common Data Elements repository that the HEAL initiative has put together. And this is an ongoing process. They are working on it, expanding it, and I think they're very open to suggestions as well. So I provide the link here, and if you click on that link, you'll get to the page you see on the left, the Common Data Elements repository, and in it you will find currently 601 scales. And the reason why there are so many is because they actually include a number of different versions. So for the PHQ alone, we have the PHQ-2, the PHQ-4, the PHQ-8 and 9. They have it in English, they have it in Spanish. So it's not completely unique, but it is comprehensive in the sense that you can really get what you're looking for. The nice thing is that this website here is searchable. And when you do get the search results, it gives you a nice Word document, like you could use for your grant application, not for your grant application, for your IRB applications, which lists all the items the way that a participant would see them. It includes information on how you would score that scale to get the actual value that you would want to use in the analysis. And it also provides references that are relevant to citing that work. That scale. So it's a really practical and great tool. Next slide, please. The problem is that if you put in the search term recovery, you will currently get two responses. And that is the HAM-D, which is a measure of depression, which is an excellent measure of depression, but certainly not encompassing all of recovery, and the BARC-10, which does get used quite a lot, but isn't the only measure of recovery. So there is a number of other domains here, which I'll get to in a moment. But I think importantly, if you want to have more things in a recovery domain, I think it's up to all of us doing research in this space to suggest these scales, to use them in our work, and to actually tell HEAL and other people what we are using, so that we can inspire each other and saying, this really worked for me, what worked for you, and we can all kind of figure it out together. So I don't know, is this particular R24 HEAL initiative funded? Daniela, Shreya, do you guys know?
Yes, it is.
Perfect. So did you also have to do this kind of like reporting, like, they say you're collecting data and please tell us which one of this drop-down box you're getting, like I'm showing the bottom left here?
Not quite yet, but we will go in that direction once we award some like pilot study funding.
Perfect. And I will say it's definitely tedious. Like it's definitely one of those things like, oh, here's another email, here's another thing I have to complete. But there is a really good reason and cause behind it. So I do encourage you all to do it, to upload your scales and to use the drop-down identify if you're using overlapping scales. Because of course, the more we are using overlapping scales, the more we can combine data sets and build on each other's research. And I know that Emily, who is here, is doing a lot of great research in terms of open space and sharing data. So she'll probably re-emphasize that point as well. So please do take the time to tell the HEAL initiative about things that are missing and things you're recommending. Next slide. Is it only for peer recovery data? No, and a great question, Kim. Thank you for asking it. So here are it actually started, if I'm not wrong, like we talked to the HEAL data stewards 2 years ago or so when they started doing this kind of like pulling together of a repository of scales. And actually we showed them our repository of scales, which I'm going to go to in a moment, and showed them how we do our Word documents and how we kind of like structuring them. And I don't know if they took it from us or just like a universal thing and they got it from somewhere else. But they started with trying to find consensus on how to measure pain. And there's a lot of different dimensions to pain and different ways of measuring it. And I'm linking here a paper about what the process was that they used to come up with like a consensus of what people should consider a common data element, what they should be using. And I'm imagining they did a similar process for these other domains. And here I list, and this is not an exhaustive list of what's in the HEAL common data elements. These are just some of the things I pulled out, which I think are of relevance in the recovery space for a variety of different reasons. So they have a lot of different things. And specifically to your question, there's like several measures, for instance, for global satisfaction with treatment, which is an important one to have in here. And then satisfaction overall, and those kinds of things. So this is just an idea or a teaser, so to speak, for you all to consider what kind of domains are currently covered. And then as you look at this list, think about what's missing and what should be there and what you would recommend for those domains. Thank you, Kim, for that question. All right, next slide. So as I mentioned, we also, for our R24 and for just like you guys have your network building thing, we do as well, and ours focuses on recovery community centers. Harm reduction behavior is considered indicators of recovery. Great question. I'm going to touch upon that in a moment, Julia. So we as well started having a scale repository, and these were just things that we knew that we enjoyed using in our work, and we enjoyed seeing data published on these dimensions. And we just decided, let's put them all on a website and let's create a nice overview of them, so to make it easy for people to consider it and then use it. And if there is a copyright fee, to let them know what it is and how to go through that. And if there isn't, if it's free to use, to note that as well. So on our website here, the Health for Flourishing website, you can find all of these scales. And if you click on the links, like for instance, Neil et al. 2016, you will get that Word document that summarizes the items, and not to summarize, that provides the items verbatim, the answer responses verbatim, tells you about the scoring and gives you the references for that work. And these are the dimensions that we have covered so far, which is to say recovery-specific constructs, where we have included the BARC-10 like the HEAL initiative has. We've also included the longer version, the ARC. Then we have included the SURE, the Substance Use Recovery Evaluator. And we have also recovered the recovery progression measure. And we're certainly open to others as well. This is just the starting point, and we hope that people suggest things and flesh out this repository. We also have evaluation of services as another domain in terms of like how our peer recovery support services, or in our case, RCCs, interacting with the people who walk through their doors. And there's a number of different dimensions you might consider, such as satisfaction with the service and client evaluation of self and treatment. But then there's also this group cohesion thing, like RCCs is not a service delivery place, it's a community. So we're thinking, well, what else, how can you get at the community piece of that? And we included a group cohesion measure for consideration here. We also included, and we have no citation for this, but we just included our thoughts on it, the different ways in which RCCs can confer benefit. And this is why we're hoping that people chime in and provide feedback and saying, I agree with this one, I disagree with that, and you're missing out on this one. So it's really a sharing space for us for how you could consider how RCCs are conferring benefit and then extending it to other places. Absent from this list of domains, just as Julia highlighted, we don't have harm reduction on this list, and we really should. And to be honest with you, so there is a bit of a tension in the recovery support services space, and especially recovery community centers, and harm reduction. A lot of recovery community centers do harm reduction, but some of them also don't. And there are particular stresses that are being placed on RCCs if they consider doing harm reduction work. This is a topic we want to discuss in our seminar series in September to kind of build towards that. But it's a really great question and a really important issue to tackle, Julia. So if you have time offline to chat with me about that, or here, if you're willing to chime in, it's something that we are very actively thinking about right now. All right. Moving on to the next slide. Perfect. Thank you, Julia. I will definitely be reaching out here. Just to the screenshot so I would remember your last name so I can find you. And Daniela, is it possible that you might get me the email address? Wonderful. So the work that I mentioned, the repository, was our R24 team. I think you all might remember Robert Ashford in this team here as well, who was part of, starting us out as well. And this is the rest of the team. Many of them you know really well. So this is who did the repository and who started our work in this space. Moving on to the next slide. So when we created the repository, we knew that we liked them as scientists, but we were wondering what actually directors of RCCs would think. Sorry, let me just pause to read Lindsay's comment. Unless, Lindsay, you want to unmute and ask your, make your point?
Yeah. So if peers are not providing, if you've got certified peer specialists, which RCC should, that's the whole point of the organization, and they're not providing harm reduction and they're not offering harm reduction services or using them, they're being unethical, because as a peer, we are required to use all of our toolkit, right? So if you are only going with one model like abstinence-based, then that is unethical.
Yeah, so 100% agree. And I will say that, like sort of like a pillar of recovery community centers, as I understand it, is this multiple pathways. They are never prescriptive. I never say abstinence is the only way in which you should go. There's always multiple paths, and your goal is your goal, and you'll be supported in that goal. The tension comes around the fact that RCCs are financed in a number of ways, and some of it is just philanthropy and donations, and some donors are uncomfortable with harm reduction, and they will say, I will not fund your RCC if you do explicit harm reduction work. And then in some states, legislation is in place. So they're saying, if you are offering clean needles and somebody dies, we're going to hold you liable and accountable. So those are the stressors. It's not a moral judgment so much as a consideration of how to keep the doors open for RCC. That's at least how I have heard it. Have others heard it similarly, or with other contentions?
So I know that even the grants that you get from, because I worked under a state grant, I've worked under federal and state grants at an RCC in Texas, and we were not allowed to buy needles. But so harm reduction services is a whole myriad of different things. But organizations who are abstinence-based only should not be hiring certified peer specialists, because they could be reported and lose their certification for that.
Yeah, and you wouldn't want to be working in an environment if that's not the toolbox you get to use. I hear you. Yeah, great point. Great point. And to the point of measurement, like we should be including good measures about how you can capture harm reduction activities that you are offering as an RCC or another place that has services, as well as what kind of harm reduction behaviors people engage in. And that's definitely something I'm writing down for myself to add to our scale repository. Jordan, do you feel comfortable speaking up, or shall I read your comment?
No, that's fine. I'll comment. Like I said, I feel like for organizations and funders, like that's it's an easy way for them to, essentially cop out, because, understanding that there's, the set of harm reduction strategies, but then there are, the principles that are supposed to guide our work in this space. And, we can incorporate the principles of harm reduction anywhere, even just starting with the core principle of autonomy. How are peer organizations delivering their services? Are they delivering autonomous services? Are they, where the principles are being centered? I understand legality reasons, depending on what state you're in and environment, not being able to do things like syringe distribution or test strip distribution, but where are the principles? Because there's a lot of people that, they can rattle off harm reduction strategies, but they do not understand the principles. And so much of that is directly tied into everything that is at the core of peer support work.
Right. And I think, and correct me if I'm wrong, for me, like the core uniting factor is the respect for the person seeking recovery, who as a peer you support, right? And that respect means you're meeting them where they're at, and you're supporting them and keeping them safe as best as you can, without superimposing your own path and your own values on them, but supporting them where they're at. Is that about right?
Yes, I'd agree.
Exactly. And that would then, of course, lead to harm reduction work to be sure that's highly congruous with that.
Can I ask another question? It's kind of separate. And I came in late, so you might have already explained this, but how does the Healing Initiative and the data you're collecting, how does that play into the behavioral, the SAMHSA's behavioral health integration, BHIT, so the behavioral health integration technology thing that's happening right now?
I don't know. Who is funding the behavioral health technology initiative?
So it's SAMHSA is the substance use mental health. Yeah, SAMHSA has they're doing a behavioral health integration, and they're with technology. And I'll put it in the website.
Yes, perfect. If you can put the website in the chat, and I presume maybe I'll get the chat afterwards, I can check out that link. So I did not know that SAMHSA was doing that. So I will say that SAMHSA and NIDA are two different entities. And NIDA, of course, is focused on conducting science in this space, and SAMHSA is concerned on service delivery, if I can summarize in that broad scope, and they don't necessarily talk with each other, but it'd be great if they did. So the HEAL initiative, which I was mentioning, is an initiative done by NIDA as well as other institutes of health. And their goal is to enhance science in this space and to make scientists use the same measures of, to measure the impact of the work that is being done in terms of support and recovery and treatment, as well as understanding mechanisms. And I'm not sure, I'll have to look into what SAMHSA has here in terms of behavioral information technology. And I will say that does touch on probably my last slide of the talk today about the differences in the kinds of data we're collecting, right? Are we collecting data to answer a scientific question, or are we collecting data to kind of, to self-evaluate services and streamline things, or for the actual person in recovery to kind of like see their own journey and help them figure out where they are at and the next steps that are most important to them. So it's more like I want to say clinical way of capturing the data. And those are two very different things and have very different considerations. Oh, and Shreya reminds me that I should be moving on, so I will be moving on. Sorry about that. Feedback from RCC directors, but great questions. And as I said, I will touch upon on the last slide. If you can move to the next slide, please. Perfect. So what we did is we basically identified RCCs across the country, and we called them several times to remind them and gave them a survey. If you go to the next slide, we do have a paper here if you want to look at how we did it specifically. But we basically selected 7 measures that we wanted to see how it would actually capture whether or not people made progress. So we looked at the life goals, the BAC, a measure of quality of life assessment, the SURE, a measure of flourishing, client satisfaction questionnaire, and then that other scale that I mentioned where we made up items. Next slide. The way we asked it is what we did in our survey to RCC directors. We first provided an overview background. This is what it would do. Then we gave them the actual items that a person would respond to in order to measure their recovery. Then we would provide information about how then on the other side, the person collecting the data would use this information to score it. And then we asked them to evaluate what that data would do for them. And we asked them, do you think that participants at your RCC would actually show progress on this measure if you administered it over time? So you first give it to them when they walk through your doors, and then you give it to them 3 months later. Do you think that this score would go up for them? And then if it did, do you think this is a measure of the impact that your recovery community center had on that person? Next slide. This is what we got. The answer for all of our selections is that people thought that there would be progress made a lot on them. Most people agreed with that. And they also agreed that participants, that the improvement that would be seen would be due to the activities that they had access to and the support they received at the RCC. So there was substantial buy-in from the directors. However, if you go to the next slide, if we ask them which one of them is the best measure and which one is the worst measure, we start to see that there is quite a spread. So kind of getting the gold standard of like, this is the measure that everybody should use, that is harder. Next slide. So in terms of thinking about what are the best and the worst, we asked them why they thought things are best or worst. And in terms of the scales that people, RCC directors liked, is something that's brief and easy, like life goals and the BAC 10 and C squared. They're easy and straightforward. They didn't like things that are clinical sounding because it reminds you of going to the physician's office and being greeted by a clipboard that you have to fill out for 3 hours. They wanted things that are very relevant to the RCCs and specific to the services that they provide. And they wanted it to be very recovery focused, which clearly the BAC 10 does. The things that didn't work well, that weren't well perceived, are things that are long and clinical. That's why the PERMA, which is a measure of flourishing, kind of fell out. And we thought flourishing would be a really cool one to have. Some felt, if it was focusing on use, that was not something that the directors liked because recovery is multidimensional. And again, it was supposed to, if the questions didn't sound like they would fit for somebody in recovery, that's a reason why RCC directors also didn't like it. All right. Oh, 2 VAC questions, but also not really liked. Next slide. I can hopefully wrap up on good time within time. Conclusions. All of these scales are liked and have face validity, but much needs to be done in terms of having a gold standard. And I think I already mentioned here that, the lessons of like it can't be too clinical, and that there are a lot of facets to measuring outcomes of peer recovery support services. Next slide, and here I will really speed. Shrevia, can I have like 3 minutes? Is that okay, or should I stop here?
Just 3 minutes.
Okay.
Okay.
Thank you. So we'll go to the next slide because I already mentioned this about self-study versus, when you're doing it for yourself versus for research. Here's the list that we picked, and luckily, next slide, please. You all get the slides. This is our team. We're partnering with the Detroit Recovery Project and the Northern Ohio Recovery Association. So these are the scales that our team discussed at length, and we all agreed this is what we would want to ask. Next slide. Our goal was to study people who are receiving medications for opioid use disorder and are within reach of an RCC, and we're just following them naturalistically to see if they do or do not use the RCC services. And the real goal of the study is to test the appropriateness of study procedures, which is why I'm sharing the scales with you all. Next slide. We picked the SURE as our primary outcome, which has several dimensions, and the dimensions are substance use, coping without substance use, self-care, relationships, material resources, and outlook on life. And then, in addition to the SURE, we asked these other things that you have here to see if these other measures are better at getting those dimensions than the SUREs, or if the SURE does it appropriately well, in which case we could just have 18 items instead of 18 scales to do this. So, and these are the ones that we have. All of them are in our repository, and I'm happy to email them with you all if anybody is interested about why we chose these particular scales. Next slides. Next slide, sorry. We also checked pragmatic things like, did they attend the RCC? Are they satisfied with the services? What kind of supports, emotional and so forth, did they actually receive at the RCC, to really dig into the pragmatics here, because the pragmatics are important in this setting, as in most settings. Next slide. Timeline follow back. These are for you to take home. This is how we organize our Excel sheet to put the data together. And if we go to the next slide, I'm also just sharing the resources we have for how to do a timeline follow back. Typically, if you think about timeline follow back for just measuring substance use, in our case, we also asked about RCC attendance, and you can do it for any kind of peer recovery support services. And I encourage you all to do it. And these slides are simply here to say the kinds of processing of the data we do afterwards to make sure that it's in the shape that we need it to be. All right, and I think if you can just speed me through the next ones, I mentioned my conclusions. So multiple dimensions of recovery, measuring them is needed, is asked for, and is doable. There is no gold standard yet, maybe there never will be, but the conversation is ongoing, and that's important. That's really to flesh it out. And I really encourage you all to vote with your feet, fill out those HEAL surveys, email us, put your scale on our repository, share with your colleagues about what works and what doesn't. And then the last slide, I simply included, if you go to the last slide, about our upcoming seminar, shameless plug. If you guys want to know more about linking recovery support services with clinical settings, please join us on May 3rd. Thank you, and apologies for going over. Appreciate the conversation.
Thank you so much, Bettina. I'm sure all of us would agree that this was a wonderful presentation, and In the interest of time, we will move on to the next part of our session, but I do encourage you all to keep those questions coming, and this chat is firing up and I love to see it that way. So please keep those questions coming, and I'm sure Bettina will answer as we go along. Karen, if you could please bring up the announcements from BWell. Thank you. To claim your CME credit, you must text by midnight tonight. Please text attend 100-957-40 to 844-502-1338 to record your attendance. Next slide. Do you have a research or an evaluation related work in progress that you would like to receive feedback on? CSTAT offers you the opportunity to present a research or evaluation related work in progress and receive feedback from our community of experts. There is no need to prepare a formal presentation. We will provide you a case form to fill out and to assist with your case presentation. Please email us at cstat@utisca.edu. Next slide. The Peer Recovery Innovation Network invites you to complete a quick survey that will help us set up priorities for the future of recovery research. Please answer the survey we are sharing on the chat and help us expand recovery science. Next slide. Join CSTAT for our session titled Mitigating Grief and Loss Post-Pandemic, and this will be happening on Tuesday, May 21st. We will drop the registration link in the chat. Next slide. Finally, join us for our next Recovery Science Echo on Wednesday, May 15th at 12 noon. Thank you. And with that, we will move on to our case. Angela and Craig, you can take it away when you're ready.
You're muted, Angela.
So you can't read my lips? I could listen to Bettina talk all day long, and I really hated to even stop that because I had several questions, but I know that we're on a time crunch. So can you see the slide okay? And then not the presenter view, but the actual thing, sweet. All right, yes. I do have to use slides. I know I have 10 minutes. There's really no way for us to ask our question without sharing a little bit of context, right? Because I can't just sort of come out of the gates cold without sharing a little bit of context. So essentially, my work as a public health practitioner is I really am interested to what extent the peer support specialists improve the health of recovery ecosystems. I also keep bees and harvest honey. And so just this thought of my bees going around and the way that they pollinate the ecosystem around my house is in some ways the way that I think of how peers must populate recovery ecosystems. However, if you read the literature, and I know many of you do, around peer recovery support services, it's very difficult to understand all of the activities that they do along the various stages of change and in different settings. So how do we measure and get to the point where we're determining to what extent do they help an individual recover until we have a common language for understanding the activities they perform and the settings in which they are performed? And so I'm trying to sort of answer my personal question on the macro level while also understanding what specific activities are delivered. And so to that end, each of my studies, my two studies, one was of 5 states in Central Appalachia and more recently 9 states across various US subregions. The ecosystem model or the socio-ecological model or framework that I've been using is Dr. Ashford et al. I don't know if y'all know that person, but this recovery ready ecosystem model, right? So what layers of the socio-ecological model are peers touching? And then we have this sort of idea of a recovery ready ecosystem and these 14 types of services that would be available in a recovery ready ecosystem. So that sort of was my theoretical underpinning. My most recent survey that survey in part, but study that I'm going to ask for some feedback on was funded by the JEEP initiative, and it was entitled Measurement Matters, so very appropriate for today's conversation. And I had people, recovery scientists and subject matter experts with lived experience help design a survey instrument that improved on my earlier study and really helped me get at what activities are being done by peers and in what setting. And those subject matter experts encouraged us to think broadly. So before I used what was in the literature, and often folks are using 12 to 14 various activities that peers do, when I asked them which they did and gave them an other box, they always selected other more frequently than they selected the activities that were existing in the literature. So these subject matter experts really encouraged me to cruise all of the literature, the state level competencies and activities, and the open text that I had from my earlier studies, and create the full list of activities that peers said that they were doing across these various domains, and include all of them. And then ask peers, of these, and there were 62 exclusive activities, what do you perform most of the time? And allow them to choose as many as they liked. Well, on average, peers chose 24 different activities that they do most of the time, which is a bit of an unexpected finding. And then for each activity selected, they had to choose a macro setting. So say behavioral health care, justice system, those macro settings, and a micro setting, specifically, where do you do this? Client homes, neighborhoods, on the phone. And so for every question, every activity selected, they had 2 carry forward questions. And so the results are where we are now, and trying to figure out how to share that with all of you and put it in a peer-reviewed publication. So if you begin to look at the activities selected, this table is just starting to unpack the top 3 selected activities. So I had 659 respondents in 9 states. And the number 1 activity they selected was understanding or relating to clients or patients. Some of you may argue that that's not an actual activity, but it's the idea of being a peer. But they performed those most often in behavioral health or not-for-profit organizations, macro. And then you can look at where they perform them at the micro level: outpatient treatment settings, community neighborhoods, psychiatric hospitals. So if you imagine 62 activities, keeping in mind that all 62 were selected, and this is the order that they were selected in. So these are the top, you see that the top 10 are a lot of emotional support, right? Cruise on down. I'm not going to show you all 62 because of the interest of time, but these are the next set. And if you go on down, even number 62 got 88 votes. Okay, so imagine you have all of these endorsed. And so I began thinking, well, I'm going to hark these into the 4 types of SAMHSA support, right? We talk about these. So how do we divvy them up? And I began doing that. And some of them are still other, but we do have these 62 divided in the different categories. And so on the left, you'll see there were 10,692 endorsements. So overall, the votes, there were 10,692 votes across 62 activities. And as you can see, those endorsements, I did it by frequency and count. Most of the time, they are using emotional support activities as defined by those previous ones, followed by informational support, then instrumental support, and finally affiliation, which is connecting to social resources and other affiliations and communities out there. So first, I guess I would like to ask, or I guess I would like to sort of just get an okay, and I will finish before, but park in your mind, is that a cool way to do this? Like, is that an okay thing, sort of to begin parking those in those types? We did ask them also to use a slider bar of how much time they spent in the 4 types, and it was about 50% of their time spent in emotional. So we sort of are unpacking those. So that's one thing. We decided as a team to do that, and Dr. Henderson is here with me. But then next, so like, I don't know what to do with that table that I showed you at the beginning. You've got 62 activities, you've got a macro and a micro. The macro settings aren't super interesting because it's behavioral health and nonprofit almost all the time. But these micro settings by count are starting to be really interesting to me. So the number 1 most frequent place that folks are delivering these 62 activities are in communities and neighborhoods, peer recovery support or services organizations. And then if you were to combine client homes and community neighborhoods, so much of this work is happening out in the field and where people live. And then if you combine RCOs and RCCs, you can see a lot of work is happening there as well. These are the top most selected micro settings. So I think that that's my last slide. It is, and I'm going to stop sharing. And our greatest question, our big question is, if this were your data and you had all of these activities, I'm interested in nesting them on a socio-ecological model or the recovery ready ecosystem framework, but they don't fit squarely onto those. So what would you do with this data? How would you share it with the public? That's our question.
Thank you so much, Angela, for your wonderful presentation. I do see a question from Lindsay in the chat.
Okay, yes,
Do
I
you
wasn't monitoring
define
that
the
very well.
Yeah, do you define the activities or leave it up to the peer to decide what they mean?
Right, so the activities themselves were not defined in the survey because I wouldn't have that much room in a survey. We spent a lot of work on the front end asking peers. We had a previous survey of 565 peers where they told us in an other box how they used the words, and we took the names of the activities from the existing literature, from peer voices themselves, and peers vetted it every time. So usually the activity was more than one word, but it did not include a longer definition. Does that answer the question? Okay.
So one important question that came up in kind of our prep session was, where are you hoping to apply the use of these activities once you've kind of done that consolidation a little bit more? Is this to hopefully help us investigate mechanisms of action for peer recovery support services? Or is part of the motivation more towards, well, we just want to make sure we're looking at service utilization correctly? I'm thinking with my, health economics hat on, that is, totally different task than looking at something like mechanisms of action.
Yeah, I think the mechanisms of action is where we'd like to go. We'd like to sort of begin to see what they're doing and how can we begin to categorize them, index most common elements of peer support in various settings so that we can test them and see how they're working to improve outcomes for the individuals they work with. I'm also from a public health perspective, so I'd like to think that it's a little of both, answering a call in the literature for, we need to know what folks are doing so we can measure it and decide how it's making folks change behavior and have better outcomes. I'm really interested in also seeing how these activities are mapped onto a recovery ecosystem and improve its health overall. So a little of both maybe, but I do, it is and really important, I think, to begin indexing these activities so that we can measure them. Does that answer the question? Yeah.
I have a question. Do you keep track of which category somebody, like which environment somebody provides the services in relation to like how often they use that specific support? Because for being in the field, I can tell you when you provide services in different areas, it tends to mean different services, right? So if you're in a home as opposed to like a recovery community organization, you can provide different, that will correlate to different services. So can you track that?
I want to make sure that I understand what you're saying.
Like,
so this,
if somebody works like for like an LMHA, right? Are they providing different types of services than somebody that works for an RCC, or can you track that?
yes, we ask them who their employer is and can track then what activities they perform based on their employer. Yes. And most of the folks in this sample were large behavioral health organizations or not-for-profit. But there doesn't seem to be much difference across the other settings, and we're performing additional analyses so we'll be able to better answer that question. But there doesn't seem to be a lot of difference in the types of most frequently selected emotional support across different, like if you're employed by someone different, it seems like those are still the top most common activities is those emotional support activities, regardless of setting. But we're still unpacking this data. But yes, we can track that.
By employment setting, right? Or is it the individual activity linked to those micro settings?
Both.
Both. Great. Okay. And then I see Emily has her hand up.
Yeah, I love the use of the SAMHSA, different ways of support. And I think because when you were talking initially about activities, in my mind, and this is kind of back to the discussion we had when we were reviewing your case form before we all got on, but we were talking kind of about billable services, and so activities from like these really discrete, like concrete standalone things. But when we looked at the list of things that people were saying they were doing, it was like some of those things could be covered in a single conversation, right? But it was like several different ways of supporting somebody. And so I think that's a helpful move. And then I was just wondering, like, if you're going to write about and talk about activities, if there's a way that you can kind of like categorize in a different way for specific activities versus kind of the way you've done for the different types of support. Because I think that the use of activity may throw some audiences off depending on how it's described and presented and kind of like submitted as a paper.
Mm-hmm. So are you saying categorizing the settings so that the activities are already categorized by type, or are you saying
yeah, so I think because the use of the different like types of support, I think, was really helpful in like from that perspective. But when you use the term activity and said there were 62, I guess from my read of it, some of the activities were like, really, it was like a conversation that addressed 6 different things that the person needed, 6 different ways of support, but it's like still a single activity. It wouldn't be necessarily, several activities. I think if we're thinking about it from a health services perspective. Does that make sense? Or is that I feel like the word activity is what kind of threw me off initially.
Yeah.
Can I jump in with a response here, Angela?
Yes, please.
So we're doing 2 things. One, we're looking at our data with this multi-level structure where you're taking this nesting of activities within, settings and, employers into account. The other thing that we're doing, and we're going to be presenting on this next week at the NCARS conference. So it's not super interesting yet. It's actually kind of boring, but still come to our session if you would, please. But we're using latent class analysis that I'm hoping will show groupings of these activities where they're occurring together and together with the multi-level structure in which settings are these clusters of activities happening together. That's what I'm hoping the data will start to reveal. But yeah, we're on our way there. We don't have anything super enlightening for at least for the latent class part next week, but we're working on it.
Yeah, and I will say activities, it's really a weird word because what I want to say sometimes is interventions, because some of those are motivational interviewing is one of them. Some are interventions, others are note-taking required by my employer. So if you're asking what they do in a given day, sometimes it's provide transportation, deliver a motivational interview, deliver a substance use screening tool. And so really the work of a peer is so varied. Some could be categorized as an intervention that may even be billable that isn't currently being billed. And some are just other duties as assigned that I think, within that transportation relationship happens and positive outcomes can also happen. So it's just such an interesting, I think I need to dig more into community health worker or maybe job analysis studies or things like that. But here we are with this data and just finding a path forward that serves the research needs of these, like all of the researchers that are doing this work, and then also sort of serves the peers themselves and sort of how to better support them and provide training and help them know, like, what is the most efficacious thing I do in harm reduction and what's the most effective thing that I do in a primary care environment. And then that's where I get the most bang for my buck.
And hi, this is Cheryl. I can't find the hand raised. So I love all the data that you collected. And, I oversee 21 recovery community centers in New Hampshire, and it was not surprising at all to me how many things they said they did, right? Because I watch it every single day. And I think you have to remember that it's all driven by the person that walks in the door, right? And none of the research takes into account who walks in the door today dictates what my job is today, right? Today, I might
important.
need to do a resume for somebody. Tomorrow, I have to get somebody on MAT. And Thursday, I have to administer Narcan, right? Every single day is driven by who walks in the door, and who walks in the door at Recovery Center A is not the same person who walks in the door at Recovery Center B, right? And you guys need to figure out how you take all that into account. But I think, I'm a person in long-term recovery, and I've been doing peer support since 2001. So like, just having all of you here, like talking about this, just makes my heart sing, right? Because nobody ever did it. Like, we all said, yeah, it works. We're living proof it works. But now, really getting down to the nuts and bolts of how to measure this is really complex. So I so appreciate the efforts and the trying. And, I think it was Lindsay who talked about harm reduction. How are we like adding that in? And I think she made a comment like, that's how it's supposed to be. Well, when this started, it was not like that. It was abstinence only when you walked in the center. You were in the center if you were in recovery, and if you weren't, we got you to treatment, right? So over the last 25 years, this has changed to a much different model of multiple pathways, which I 100% support, but we can't forget where it started either, right? Because there are still people who believe that abstinence is the only way to do this, right? And it's hard. So I appreciate all you're doing. I don't have a whole lot of input on how to count it or do anything like that, but I would love to talk or do anything about what you're doing, or offer our recovery centers in New Hampshire as part of what you do and who you look at. So
Okay, you
Cheryl,
are
thank you
also
so
now
much.
singing to us, singing right back to
Yes.
us, Cheryl. So we likely will be following up.
yeah,
Yes.
we use Recovery Link and the BART 10, just so you know.
Okay.
And we have over 100,000 interactions. So we have a lot of data.
Yeah.
So,
Yeah. And I think you did say
Sierra
something
has, yeah,
scientifically important too, is that it's meeting someone where they're at. So how are activity decisions made based on the assessment of the person? And so I think that is an important thing that we probably aren't getting at yet. So thank you.
yeah. Thank you.
And
Yeah.
Lindsay, you have your hand up?
Yeah. Do you guys have any way of correlating the activities performed with the outcomes, or how do you measure the outcomes?
Well, that's the whole point of this work. We're not there yet, right? So how do you, if a peer is on average doing 24 things most of the time, how do you measure what they're doing with one person in one setting, right? And so we're trying to index and categorize the types of activities that are most common so that we can get to that measurement and sort of know how it impacts. And I did a literature review, and I know a lot of folks are still doing it, and we're just not there yet. I think that the discrete activities aren't categorized well enough. So people are studying outcomes. Like, for example, if you link someone to an RCC from an emergency department, what are the outcomes? We can do that, but on a broader level, I think there are a lot of things missing from how we can measure outcomes. And I know we're getting to the end of our time.
Thank
While
you.
we're at it.
This has been a wonderful discussion. Thank you so much. Thank you, Angela and Craig, for bringing this wonderful presentation and for this discussion. In the interest of time, I will call on Sierra to please summarize today's session.
Absolutely. Thanks so much for being here, everyone. We heard today from Bettina about how we measure whether peer recovery support services are working and what exactly we mean by working when recovery is so multifaceted and individual, as well as some large-scale efforts to try to kind of coalesce those measures. That fit really nicely in with our case today from Craig and Angela that deals with that problem, but kind of from a different angle. So what are peer recovery support specialists doing? Where are they doing those activities? And some of the many challenges with such a flexible and individual set of services. So both sets of presenters mentioned that they have presentations at the upcoming National Conference on Addiction Recovery Science next week. That's an entirely online conference. So hopefully we'll see some of you there.
Thank you so much, Sarah, and thank you all for joining us today at this ECHO. As a reminder to earn CV credits, please complete the post-session survey using the link in the chat. If you would like to present a case or a research study that you are working on, please email the BWell Texas team at cstat@utisca.edu. We look forward to seeing you at our next session on Wednesday, May 15th at 12 noon Central. Thank you and have a wonderful rest of your day. Thank you.